I first got interested in science and medicine probably around the age of 10, and pretty soon thereafter was convinced that I was going to go into science. One of the first things I wanted to be was a veterinarian, and then I was thinking about being a physician, but basically later on in high school I decided that what I was really interested in was science, and I had a really inspirational biology teacher who she was actually a huge fan of Richard Dawkins and his writings on popular science, and I think she really got me reading in popular science. So I would read the magazine Science. She was just really inspiring, and one of the things that she encouraged me to do was to write an article for a science writing competition in the Daily Telegraph, big British newspaper, and what I decided to write about was recombinant hemoglobin. And in addition to reading kind of the published scientific literature, I ended up contacting this researcher, one of the main researchers in the field, who was working in Cambridge at the molecular biology laboratory there, where Watson and Crick discovered the structure of DNA. Contacted him and asked him if I could interview him. And so I went out to Cambridge, did the interview, wrote up this essay, and I was actually a runner-up in the competition. And I recently realized in the last year or so, I've been doing oral history now officially for 10 years, and I realized, wow, for quite a long time I had been using interviewing as a technique back in high school. So I find that kind of pretty neat to reflect on. But I continue to have this interest in science writing and this goal of writing for a popular audience. And I went off to college and majored in biochemistry. And throughout most of my first 3 years of college, I was convinced I was going to be a bench scientist working in biomedical science. And in my third year, I got to work at the drug company AstraZeneca for a year doing bench science. But it was in that time that I thought, I love science, but I really don't like lab work. And I'd had this continuing interest in science writing, and I'd written for the medical student journal an article. And so while I was working at AstraZeneca and waiting for my experiments to run, I spent a lot of time doing some extra reading, thinking about history and politics. And I initially thought I would go into science journalism, go to a science journalism school, realized I didn't have enough knowledge about history and politics, and happened upon graduate programs in the history of science and medicine and thought, that's perfect. So I applied, was fortunate enough to get in. Didn't really know what I was getting into, but it actually was an ideal match for my real interest in science and medicine, my real love of writing, and my desire to kind of understand the social and political context of science and medicine. So that brought me eventually to the University of Minnesota, where I teach history of medicine, science and technology, and use oral history as an important component of that. So I feel like interviewing people and getting their first-hand accounts of their experiences of the past, of specific events, is a really valuable way of better understanding the past.
How did what you were trying to do change in this period? I have friends who are attracted to medicine because they want to cure cancer. Just that. And labs don't have any appeal. What things don't have any appeal? They want to cure cancer. But I'm so curious whether the idea of what you thought you were going to accomplish shifted as you went through this history.
Mm-hmm. Well, one of my first late in high school, I was convinced I was going to go to medical school and be a physician, and I shadowed a few physicians and realized that probably wasn't going to be intellectually challenging enough for me, just because there's a lot of routine and I mean, it's really valuable work, but I just thought it's not going to grab me, and that's when I thought about doing science itself. But for doing science isn't really, there's a lot of waiting around and waiting, experiments to run, realizing you made a mistake in setting up the experiment and having to redo it, and I always thought if I could just jump from being kind of a bench scientist to being principal investigator, where you run the lab and you don't do so much hands-on, but you kind of do the big thinking, the intellectual ideas, that would be ideal, but obviously that's not a reality. But as I say, I had this combined interest in increasing public understanding of science. Like I really think, things have gotten a lot better as more and more science writing happens, and even scientists are recognizing, I think, the need for them to be accessible, some of their work to be accessible, or at least grand ideas about their work to be accessible to more of a public audience. I really just thought it was valuable. There's a lot that happens in science, and some of it is really esoteric, and the public kind of might imagine those who are doing cancer research to be on the verge of groundbreaking stuff. But what I learned working at AstraZeneca was that actually there's so many more esoteric steps to kind of get into that big breakthrough stuff. And I just think it's important for the public to be kind of scientifically literate, given how important, what a premium we place on science, and how much government funding goes to science, and how much hope so many people place in kind of science and medical research. So I think scientific literacy to make a more informed citizenry is really important. And I thought science writing was going to be a way to do that. But I think, going through graduate work in the history and sociology of science changed my thinking. I mean, I still think writing for a public audience is so crucial, and I hope in my first book that I wrote, I wrote it in the hopes that it will be accessible to people beyond academia. And I know some of my friends who aren't academics have read it, so I think, but at the same time, I'm still an academic, and so I have aspirations to eventually write things that will be more accessible. But I think there's, in addition to kind of having this interest in writing to increase public understanding of science, I think it's also valuable for those who are doing the science or writing science policy to have an understanding of kind of where science comes from, and what the social and political context of science is. That science doesn't exist in a vacuum, and so I think it's vital that scientists and policymakers really have a good sense of kind of the decisions that have been made in the past that have affected scientific research or science or health policy, so that as decisions have to be made in the present or in the future, that you can look to the past to understand what worked, what didn't work, and just have a sense that, an awareness that it's not inevitable the way that scientific research happens, that there are conditions that kind of constrain the kinds of questions that researchers are asking, and the kinds of projects that are being funded. So that's, having a commitment also to then ideally having my work read by practitioners and policymakers, because I think that's a way to really potentially have an impact. But since being at the University of Minnesota and teaching, I've realized that actually the most effective way to have an impact on the way that people think about science and medicine is through teaching undergraduate students. And particularly because we in the history of medicine get a lot of pre-health science majors, so those who plan to go to medical school, maybe are already in nursing school or plan to go to pharmacy school, that these are the young people who are then going to go into practicing in the clinical field, or they're going to go on and do biomedical research. And so to give them an awareness of kind of how science happens, how medical discoveries, the ways in which clinical practice is affected by social, cultural, and political factors and economic factors, I think is really valuable. because I hope that that will inform the way they continue their education and go on to practice. And even for those students that don't have interest in pursuing careers in the health sciences or in scientific research, everyone is going to end up having the right, being able to vote, and they're already, once they're 18, they can already register their vote. And as we saw in the last election, the debates about healthcare reform were front and center of that presidential campaign. And I was actually teaching a class on women, health, and history at the time. And so I was talking about the history of particularly reproductive health and reproductive health policy. And as that was a kind of critical element of those healthcare reform debates, that I had an opportunity to not proselytize about what my political position might be, but to inform the students about kind of how these reproductive decisions have been made in the past, how we get, what was the context for Roe v. Wade, what has been the context for subsequent challenges to that, what was the reality of women who have had to, who've kind of benefited from that legislation and are most at risk if it's overturned. I can actually give information to the students so they can make their own choices, but at least there's informed choices. They can make informed choices about how they're going to cast their vote relative to these healthcare reform debates. So I feel like the teaching of undergraduate students, particularly the kinds of courses that I teach that really deal with recent history of healthcare and bring it to the present, or at least include contemporary issues into the classroom, I think that's a really key way that I can kind of do what I have always been committed to do.
And did you skateboard?
Did I escape boredom?
It seems like each right turn was because the thing you were considering doing was just too boring for words.
Yeah, that's definitely true. There's because there's always the danger and reality that you're going to get bored at some point, no matter what you do. But the benefit of doing what I do is that if I do get bored with a research topic, then I can move on to a new one. And there are endless subjects to pursue in history, particularly even in the recent history of healthcare. So my interest has definitely been sustained, and also the different elements that are involved in being a history professor. So it's about the research and it's about the teaching, and by having, with oral history as such a central focus of my work, the experience of going out and talking to people about their experiences, which is always really enlightening and really invigorating, because you learn firsthand about different people's different experiences, and it's hard to be bored when you're listening to a range of different people from different walks of life, different backgrounds, telling their stories. So yes, I think by and large, so far, I've managed to escape boredom.
People do history in different ways. Sometimes documents are central, sometimes interviews are central. What have you found interviews to contribute to what might be otherwise available?
Well, even before I get into the interview, I will say, I'm exhaustive in my archival research and using documents, using texts, using newspapers and published medical articles and whatnot to prepare for the interview. But interviewing adds a great deal to our understanding, and my understanding of history, and invariably recent history is, I've interviewed a number of people in their 90s, and that's probably and one woman when she was 102, but that's about as far back as you can go with interviewing.
I got 103.
Oh, you beat me. But there are several benefits. So in the historical texts, in the documents that I use, thinking about correspondences, meetings of minutes, reports, those types of things. Unless you're looking at diaries and personal letters, what you're seeing is a very limited pool of experiences. You're seeing, at least for when looking at university archives, you're looking at the people who are the administrators in the leadership of medical schools or different units within the university, or people who are kind of prominent within those units. There's a heck of a lot more people involved in the history and the workings of the university, for example, and a lot of these people never appear in the written record, and so that's, by interviewing people, you're literally giving voice to people otherwise hidden from history, which I think is vital. The other thing, from reading both the published medical literature, from reading newspaper accounts, and from reading these kind of documents related, coming out of institutions related to the past, you get a limited number of perspectives. You get only what was written down in text, and particularly when looking at the history of an institution. If you've spent any time looking at minutes of meetings or recording minutes of meetings, you'll see they're really sparse, so you really don't get a lot of the context. So by interviewing people, you get a lot more insight into kind of the nuts and bolts of what was going on, what it was like on the ground, and you get to fill in a lot of the gaps that are there in the written record. And then related to that, you get to add layers of meaning to our understanding of the past. By interviewing multiple people who have first-hand accounts of a given event, that you get then multiple perspectives. And certainly some people might have similar perspectives on what happened, but even the slight variations in their perspective is valuable, and even getting several perspectives that are similar, that kind of reaffirms what actually happened. If enough people are saying this is what took place, then that you can have a lot more confidence about, okay, that's probably what happened. But also by interviewing different people, and different people with different backgrounds, different who had different insights on a particular event, then you kind of expand that the kind of perspectives you can get, and get a more rounded, a fuller picture of what happened in the past.
Can you tell me a little bit about a really good day? I mean, I know, at least in my own experience, there are really good days when you get something that just, you have made a contribution to the world. And in your situation is a lot different, because you know what people would write just from the documents, because you have kind of exhaustive look at the documents. What sorts of things do you stumble upon in the course of an interview that, make your heart beat a lot faster?
Well, I guess there are a couple of things. That's an excellent question that I could probably spend a while thinking about. One of the things, and it's not necessarily all joy, but if there is something that from the written record that strikes, that's pretty clear that something controversial happened, and there was some kind of politicking, you really get to see what that was. You can identify the controversy, but you don't know kind of where that controversy stemmed from, who everyone was involved in it, and kind of what that politicking actually looked like. And so I've had interviews with people who sometimes, ideally they're willing to be on the record about it, and in a number of cases that has happened. And the frustrating part is when they tell you all the details and fill in that context, and then they say, I don't want that included. But that that really kind of filling in the gaps and getting an understanding of kind of what happened. And then one of the most exciting interviews in terms of learning something really powerful from it. I interviewed a former member of the nursing faculty here. She was here in the 60s and 70s. Her name is Ida Martinson, and she was telling me about a program that she established here in the early 1970s called Home Care for the Dying Child. And I had, I think, I couldn't believe I hadn't heard about it, given how important and kind of innovative it was. but it was this program that she set up in which that allowed children who had terminal disease, often cancer, and they were, in their final days or weeks. She made it possible for them to go home, to spend those final days at home surrounded by their families. And she was able to do that by setting up a system where she would work with nurses in the local community and arrange for the nurse to work closely with the families and to teach the families how to provide that care that their child needed. And then the nurse would come in daily, be available to provide any additional care, but really allowing the parents themselves to kind of take care of the children. And this involved sometimes, she told me one story where a young child, maybe early teenager, he had, really a couple of days at most, and they were worried that they weren't going to be able to get him home in time, somewhere outstate Minnesota. And actually she was able to arrange, I think it was the university president's plane that took him home, and he was able to die at home. He only had a few hours there, but that was really meaningful for those families. And for me, that was one of the most powerful things that I learned in an interview, and it was incredibly touching. And it's something that I believe the program continued, and maybe it still continues, but it would just seem so humanitarian and so incredible that this nurse, working with some of the physicians here too, was able to do that for those families.
Stephen Jay Gould has made us aware that in evolution, the good guys don't always win. It's not the survival of the fittest, it's the survival of whoever happened to survive. Yeah. And we knew that already from institutional experience in any area of our lives, from churches to research to writing. What do you run into as you're fooling around with these moments of change and development? Do you find yourself happening on programs that should have won, directions that should have been followed up, insights that were really pretty interesting that got swamped? I sent a note once to a neurologist friend saying, my friend's grandmother has been working on this her whole life. Where is it in the research? And he said it was a very interesting strand that got totally swamped when MRIs came in. And so suddenly everybody wanted to do that. Nobody wanted to follow up anything subtler. So I guess I'm curious about your experience with, what might have been in oral history in your own experience.
Well, the most obvious area that I've seen this was actually my first project, where I didn't actually do any oral history interviews. I used some done by others, and if it's appropriate to talk about that, because my first book was on the politics of the pharmaceutical industry in the United States after World War II, and looking in particular at prescription drug policies and legislation, and kind of really trying to get at why pharmaceutical companies have come to be so politically powerful in the United States, and really trying to kind of understand the history of the relationships between the government, drug companies, universities, and physicians. And so through that, I saw a lot of discussion about policies, legislation that could be enacted, but never was. And I think given current contemporary concerns about the price of prescription drugs, concerns about whether new drugs are really innovative drugs are in the pipeline and going to come to fruition, and safety concerns too. There was a lot that could have happened, particularly in the 1960s and 1970s, that would have changed things significantly. So for example, in the early 1960s, a congressional Democrat from Tennessee had introduced legislation that would reduce the patent term on drugs. So rather than a drug having 17 years of patent protection, well, he suggested 3 years, which was probably a bit too extreme, but really kind of aware that the long patent term on drugs really increased the potential for profit from drug companies, and he was concerned that they were profiting too much. I mean, there's a lot to be, it's not a clear-cut case for sure, and that's, I mean, he had no support for that piece of legislation. But given the strategies that drug companies, and it's not just drug companies, I mean, other industry sectors do this too, but the ways of kind of manipulating the patent system to keep getting extensions for really things that aren't truly innovative, I think patent reform much earlier could have stymied that. And then there were other things that could have helped minimize the cost of drugs. So one of the other pieces of legislation he and then subsequent Democrats tried to introduce was to have physicians, instead of prescribing by brand name, to use the generic name of a drug. So this is not a prescription drug, but Tylenol would be the brand name and acetaminophen would be the generic name. So rather than prescribing Tylenol, prescribing acetaminophen. And that way the pharmacists could give whatever, could fill the prescription for whatever drug was cheapest, or if the patient wanted the brand name, then they could do that. But perhaps not surprisingly, physicians, the medical profession, were really against this and said, no way, this is circumscribing our authority. And of course, drug companies were, no way, because that's going to really cut into our profit. But given the debates now, and subsequently in the 1970s, states actually started passing laws that would make it so that physicians had to prescribe by a generic name, and if they wanted a brand name drug, they could list that specifically, but the standard became generic drugs. And while, you know, there's sometimes issues with generics, I mean, a lot of the arguments for scientific opponents, arguments for opposing that legislation, which were actually pretty valid in the 1960s, was that generic drugs weren't regulated the same way as brand name drugs, and so weren't tested as fully. But from the late 1970s, the FDA, Food and Drug Administration, actually began more stringently testing generic drugs before approving them for market, and so now you're at the case where actually they're both regulated to pretty much the same extent. But if at least those two pieces of legislation had moved forward, we'd be having a very different political discussion nowadays about healthcare costs, and particularly prescription drug costs.
This leads to another matter. Do you run into heroes? I mean, if you're looking at situations that could go one way or another, you're looking at a range of ways that labs are managed, that think tanks are managed, that all sorts of crucial institutions are managed. Have you run into heroes in that process?
Well, certainly I mean, at this university, which is where my oral history project on the Academic Health Center was focused, I mean, there are, well, I mean, you could say that everyone working in the clinical field or biomedical field at some level is doing, you know, really valuable work. And there are real kind of success stories, kind of heroic stories that have been celebrated in the institution's history. So with the first open heart surgeries that were performed in Minnesota by Walt Lilly High and Richard Varco in the 1950s. Now both of those had passed away before I was able to interview them, although I interviewed Walt Lilly High's wife and got some sense of kind of what the culture was and what the degree of excitement around that work. And then John Najarian, Dr. John Najarian, who's a surgeon here and was chair of surgery for a good few decades, pioneered kidney transplantation, and actually the transplant program here was one of the best and quite pioneering in liver transplants too. So he has been celebrated as a heroic figure in medicine. And then university was also a leader in bone marrow transplantation. So those who were really key to setting that up, Dr. John Kersey was one of those individuals. I mean, those are really kind of obvious, really kind of fantastic moments for medicine and for the institution. And then, we're always more familiar with kind of medical heroism in terms of the health sciences, but there has been plenty of kind of really groundbreaking work within nursing, pharmacy, dentistry, public health, and there is the I think that Ida Martinson, the nurse I told you about who set up home care for the dying child, I'd say that that's pretty heroic in a sense, in that she made a substantial difference in people's lives. Now, it may not be a huge number of people's lives, but I think kind of how we measure heroism is relative, and and she's just one example in the School of Nursing, but I think there are every day, I really think in the healthcare field every day there's kind of amazing things happening on the ground.
Well, when we think of heroes in medicine, maybe first of all one thinks of just raw brilliance and dexterity. Surgeons have to have good hands, and people who develop devices have to just be smart and be able to bridge biology and engineering, and so you get that, and I suppose the ordinary person can't necessarily follow that at that point, that having a certain genetic capacity just wins. But I guess I'd hope from an oral history of the kind you're doing to get a sense of what sorts of virtues are necessary to make the whole thing work, to make the roads that are taken be roads that don't get regretted 10 years later. People who are able to figure out what the right thing to stand for is, what the right thing to fold about is. People who are willing to simply be multimillionaires, as opposed to that kind of Larry Ellison yacht kind of wealth that isn't, in view in these areas. And so I'm thinking, perhaps just in terms of qualities of character, I was kind of put onto it by your story about the nurse. It seemed like there it was brains plus heart. What do you see?
Well, I actually have something that even getting before that point, we're talking about kind of the natural kind of talents of, say, a surgeon having good hands. I think what's important to remember about these kind of historic moments in medicine is that it's not just the surgeon working by themselves, that the nurses and the nursing assistants, but particularly the nurses, are critical. And in the case of the cardiac surgery, and this I got from interviewing physicians and nurses who were here working at the university at that time, that the people working in the clinical laboratory at the hospital, they were crucial, because they were taking the blood samples, they were analyzing those blood samples and reporting back to the nurses and to the physicians, and that helped figure out kind of how to take care of the patients when the patients were struggling. And without nurses, there'd be no post-operative care, and so it's never a case of kind of one single hero. And actually, part of that cardiac surgery, the great innovations there also were hinged on being able to organize a blood drive, because you needed to have substantial volumes of blood to use in that surgery. And so it was really the surgeons, with the help of others, who kind of orchestrated this blood drive. There were lines apparently going down Washington Avenue to do this. So that's one important kind of piece I wanted to add to this kind of heroic piece. But I do think undoubtedly people who have worked in these areas and who have achieved great things, it's been invariably at some personal sacrifice. The dedicated hours that in these people are willing to spend at work and maybe sacrificing time that they have with their families. And as you already noted, I mean, it really is about heart and what has motivated these people, the Ida Martinsons, the John Najarians of the world. And I think heart and kind of a commitment to helping people and making those who are suffering suffer less, and potentially curing people. I mean, I think I really do think, I don't think you can go into a field like healthcare and not have, and be willing to work long hours unless you have that kind of drive and motivation to help and to make a difference. And there, some of the things that come through in the interviews I've done, particularly, in understanding the cardiac surgeons, the great cardiac surgeons that were here in the 50s doing that open heart surgeries. I've heard some things about their personalities that they were, they weren't necessarily nice to work with. I mean, they had big egos, and those egos were derived from the work that they were doing. But that, so there is also potentially not to minimize or undermine the kind of compassion and the commitment to help people that's there, but there's also pride that's going to be, in some cases, that might be a driving factor, or just wanting to kind of achieve and be the best that you can and be the best at something. So I think whether that's there in every case, but I think in some cases it certainly is there, and certainly no one in academia is in it for the money. I think whatever, certainly, especially when kind of technologies or drugs that develop out of the university's work can become patented, then there's some revenue to be gained. Although a lot of that time that income goes directly to the university and not to the individual. But similarly, even those who go to work for industry, for medical tech companies or pharmaceutical companies, they might be quote unquote profiting more, having higher salaries. But I think there's still going to always be that commitment, that compassion, that drive to kind of make a change, make a positive change, and really help people.
You're in an interesting position as a teacher of baby doctors, and probably baby public health specialists, and maybe baby NSF officials, to shape the next generations, and presumably what you draw on in deciding how to teach and what to encourage people to strive after is the work you've done in oral history. How do you make that connection? What are you trying to do as a teacher based on what you've seen as an oral historian?
Another great question. One example I can give in my Women, Health and History course last year, one of the focuses one of the things that we talked about was female healthcare professionals, and we looked at kind of the history of women physicians, particularly the struggles for women to even be granted access to medical schools in the 19th century through the 1950s. And so you read what historians have written about this, what historians have written based on archival material, but I came across this really invaluable oral history collection that was done, I think, by the Pennsylvania Women's College of Medicine. I can't remember if that's the correct name, and it's since become a different name and is now co-ed, has been for a while. But some women's historians, did oral histories with female physicians that had gone to school from the 20s through the 70s. This was compiled late 70s. And so in addition to assigning the texts, the kind of secondary literature, what historians have written, I assigned those oral history transcripts. Likewise, when we got to nursing, again, we're reading a lot of great historical narratives from historians about what nursing was like in the mid 20th century, but then also assigning the transcripts from the oral histories I've done with nurses who worked at that time. I mean, that brings to life. It brings that history to life. It makes it more tangible, more real. And so instead of just reading potentially all the readings I assign are not turgid or unengaging, but reading texts that you don't necessarily get the sense of the people involved. You don't get a sense of what it was like for those actually doing that work at the time and what those challenges and struggles may have been. But reading about it from the first person perspective, from these oral history transcripts, and we can also use audio excerpts too. I mean, that just gives a whole different perspective, that they actually get to hear what it was really like on the ground. Again, it fills in those gaps from the textual record, and I think the students really respond well to that. And so while I use oral history as central to my teaching, and also one of the assignments I have the students do their own oral histories with, one interview with a female family member we read about the history of childbirth too, and so I have them do interviews try and do an interview with a grandmother or an aunt or their mother or a friend of the family, to interview them about their childbirth experience, so they can see themselves what you can gain from speaking to people about their experiences in the past, and that it brings to life the text that they're otherwise reading. So I think that's really valuable. I mean, I also integrate into my teaching the material culture of health and medicine. So we have this fantastic history of medicine library, the Wangenstein Library, just down the corridor here, and they have a number of artifacts from the 18th to 19th century, and also they have some documents written by Florence Nightingale. So I also bring these into class, and one of the kind of more gruesome artifacts that we bring, there are old obstetrical and gynecological tools from the 19th century. We bring those to class, and the students get to handle them and see, wow, that's really kind of looks barbaric, or that looks kind of really scary. But I think both bringing in the material culture and having access to these oral histories really kind of gives a sense for the phenomenology, the actual experience of doing and being there at that time.
And how does history of the kind you teach contribute to the formation of doctors?
Well, I like to think that most critically, it helps those future physicians understand the context for medicine and how decisions are made, both kind of clinical decision making and broader policy decisions that impact what it is to practice as a physician. That, as I said earlier, that it's not inevitable that we practice medicine this way. So for example, a good example of this, another course I teach is on technology and modern medical technology in modern America. So trying to understand why American medicine in particular is so technological, so technology driven, and that has the consequences of really ratcheting up healthcare costs. And so one way of kind of showing that our dependence, our first go-to in American medicine, is really scan them, like X-ray, CT, MRI, just do all of them. We might not necessarily need it all, but let's just do it just in case. Whereas in other countries, countries like the UK, Western Europe, that's not necessarily the go-to. Invariably it's not. It's much more kind of relying on physical diagnosis, other kinds of tests, and not jumping right ahead to say MRI. And so what the students learn from the reading and from the lectures that I give is that in part it's not inevitable, it's not kind of a clinical imperative that those big technologies are used first. It's partly to do with how technology got introduced into American hospitals. It was some of the first X-ray machines, which were introduced in the 1910s. Hospitals would buy those X-ray machines, but didn't actually start using them for 10 years late, until 10 years later, in many cases, or at least they didn't use them in routine until the 1920s. So why do they have these X-ray machines if they're not using them? Well, in the 1910s, having X-ray machines was a way for these hospitals to say, see, we're really advanced, we're really scientific, look at what we have, look how fantastic we are. You really want to come to our hospital and pay for your medical care here because we're at the cutting edge, we're really technological and scientific. And to some extent that is still a thread within American medicine, and I think that you ask most people on the street about the status of American healthcare, say it's the best in the world. We have the best healthcare. Like if you're even if you're in the UK, you would want to come to the US if you've got some like really intractable disease. You're going to get it. If you're going to get it cured, it will be in the US. I think that's something of a myth, but I think the fact that the notion that Americans are willing to pay for high-tech medicine, and that the assumption that if you pay more and you use newer, shinier things, this is like oversimplifying, that inherently what you get is going to be better. And this transcends medicine. I mean, this is like the big new computer comes out, like, okay, is it necessarily better for what you need? Or is it you just assume it is because it's bigger and it's more expensive? Same holds for medical technology. It's not inherent that you necessarily need that. So understanding how hospitals and how physicians decided whether or not to use, and the ways in which they use those new technologies. And then an actual distinctive feature of American medicine is the legal aspects of medicine, the fact that so many lawsuits have been filed against physicians in the US, and increasingly so, especially post-1970s. So there's within American medicine, and I'm sure this is not unique to American medicine, but is particularly an important feature here, is that physicians have to practice defensive medicine for fear that they'll get sued if they don't. So, just in case, in many ways, patients expect, you go to the physician and they don't prescribe you something, patients often are like, well, what am I paying you for? What did you do? So I think it's a lot easier, it's a lot safer for healthcare professionals to say, well, let's just submit them to as many tests as we can think of, cover all our bases, so that if something turns up that we missed, we can at least say, but hey, we did all of this. So I think that element of having to practice defensive medicine because of the litigious culture here. So, teaching students about this, teaching about how we got to these places, and that these are not, the reason for our reliance on high-tech medicine is not inherently isn't a clinical imperative all the time, that it is informed by these kind of cultural, social, legal dynamics. That's what I hope to teach these potential, baby doctors in the making, nurses in the making, so that when they go into practice, that they don't immediately assume that the way they have kind of learned to do things is necessarily the best way or the right way, that there are other ways to think about kind of ways of practicing medicine than this kind of defensive medicine or this resort to high-tech medicine, and that if enough medical students and physicians are able to question, and it's not to say question so that everything is wrong, that's not what I mean, but just to not take for granted that everything is as it should be, because that's the way it's always been done, but to really kind of ask questions about why are we doing this, what are the kind of factors that have contributed to this being kind of the path of action. Is that necessarily the appropriate thing? Let's to kind of think about how we got here and whether there are other ways of doing it. So that's kind of to be more critical in their thinking and not take in things necessarily, assuming things are the way they are because they need to be.
Imagine doctors come into a situation in which there are very well established standards of best practice, have a lot to do with protecting their clinic against inexperience and against lawsuits, however frivolous, that might drain resources. And I mean, one way to take what you just told me is that what learning history will help my doctor to do is to be more frustrated and sadder about the way she has to practice medicine. And I kind of see that on her face sometimes, because she's way smarter than you need to be to follow the computer program's recommendation
Right.
for this set of symptoms. Do you see doctors as having, and maybe senior people, younger folks are going to follow the rules. Do you see doctors mid-career having the wiggle room to take what you're telling them seriously?
Well, I think, absolutely. It's always going to be, if you have more security within the institution, within your career, more kind of power, institutional power, then that is going to potentially free you up to kind of be more open to other things. And I can't speak to, I can only kind of relate this to the physicians at the university who I've interviewed. And certainly people like John Najarian and Walt Lillehei, who were doing these innovative surgeries, they were taking risks, and risks that played out, and very informed risks, and that's not quite related to the question that you're asking about kind of taking more, I would say, more like smaller scale in terms of being so transformative in medicine. But I think I'd like to think that there's more flexibility, there's more possibility for that mid-career at an academic health center. I can't say that for certain. What I can, the situation that springs to mind is not about a physician, it's about a nurse administrator, but I think it's still quite telling. In the 60s, the way that the wards were ran in the university hospital was that so-called team nursing, and not just here but across the country, that for every patient would be attended by a team of nurses, depending on, so whoever was on shift for 6 hours, they'd have whatever patients are responsible. Shift changes, another nurse comes on, is attentive, and by that you didn't get continuity of care. So every time a new shift, a new nurse is working with the patient. Marie Manthe, who was Associate Director of Nursing at the University Hospital, so ostensibly she's got some kind of status and authority in that position. She came up with a way of reorganizing nursing. So instead of the team nursing, it was called primary nursing, where a single nurse would be responsible for a patient throughout that patient's entire stay. And so while obviously that nurse would have to go off shift, but she would oversee that patient's care by making sure the nurse who replaced her while she was off shift would have all the information, and she was primarily responsible for that patient and overseeing that patient's care. So that significantly changed things on the wards, and Marie, when she instituted this, she didn't ask for permission. She had had the ear of the hospital director and some of the kind of clinical chiefs, like one I think in particular, and kind of talked about instituting this and trying it out on one of the wards. I think it was called Project 32, Ward 32, and she instituted this. And at first, like, physicians, nurses, like, oh, like, what's happening? This is like completely like, what is going on? But in pretty short course, she said, I mean, suddenly everyone realized this is a much more effective and efficient way to do this, much more efficient. It's saving time between the nurses, it's increasing the quality of patient care, particularly continuity of care. And so that, I mean, I think that was possible because, in part because of her career status at that time.
Well, one thing I've learned from my limited conversation with healthcare professionals about their lives, especially nurses, is that the responsibilities articulated in the job description and the responsibilities that are actually taken on diverge very widely. And nobody really wants to be on the record about that divergence, although you get hints of it. But you begin to see that there's this paper picture of how the thing works, and on the paper picture you see nurses as more or less interchangeable because their jobs are specified in very particular ways. And then there's the real picture, which is strange and fascinating, and I wonder if you run into the unofficial story in the stuff you do.
Yeah, actually, I'm glad that I do. One particular story is coming to mind right now. I interviewed several nurses who were doing nursing in the 50s, late 40s, 50s, early 60s, and from several of them I heard, when the new interns come on the wards, they don't have any experiences, but the nurses who are there, even if they're junior nurses, they have experience. And so, but certainly for the more established nurses. So an intern is going to, come and see the patient, and oftentimes they would say, well, they weren't necessarily sure what was going on or what to do, or they certainly had some uncertainty about it. And the nurses had that knowledge. While they may not have had the kind of legal right to do that practice, they were still there to assist the intern and kind of guide the intern in kind of how to do things. And sometimes you would get an intern that was too big for his boots, and because it was, pretty much all men in this time period, who would maybe be disrespectful of that nurse's knowledge, but they would learn pretty quickly that actually they needed the nurses. And so there's certainly, this is talked about in the records, and I think in other places too. I interviewed this one nurse who before coming to the University of Minnesota, she had worked as an army nurse in some of the army bases, and there was relatively few physicians and more nurses, and it was really the nurses who were charged. They were the ones who were running the wards and doing a lot of that care. And she talks about doing some of the work that would typically be defined as physicians' work, but because of the realities of practicing and who was there and what was available, she did a lot more than had she been working at a community hospital or a non-military base. So yeah, I mean that has come through in the interviews with the nurses for sure.
Thank you.